Hello, welcome to the Renal Board Review course. My name is Adina Voiculescu. I'm a nephrologist and interventional nephrologist at the Brigham and Women's Hospital and Brigham and Women's Faulkner Hospital. I have a particular interest in ultrasound, and I would like to share some of this knowledge with you today. We are going to talk about fundamentals of point-of-care ultrasound, with my focus being on image acquisition. We as nephrologists are particularly interested in performing a volume exam in the patient as well as the assessment of the kidneys. So with about a 5-minute ultrasound examination, we are able to answer several questions in regard to kidney dysfunction as well as volume status. It is important to establish a routine for the performance of the entire ultrasound. One part was to sit right next to the patient on the right side. The second part is positioning the ultrasound machine on the right side of the patient as well, while you can look at the image and you face the patient. This way, the movements of your hand and the movements of the images you obtain will be the same, and it will train your eye to adjust your image capture according to the movements. The next step is to determine what you're going to look for. As a nephrologist, we are obviously interested in the kidneys, the bladder, and to assess the volume status. Therefore, we will have 3 parts to the point-of-care ultrasound exam, and if we focus just on obtaining yes and no questions and information, the exam should take about 5 minutes once you have established a routine. So let me show you first which probes are best selected to perform the entire exam. There are different probes on ultrasound machines, of which one of them is the so-called sector scanner. It has frequency from 5 to 11 megahertz, and it has a relatively small footprint. This probe can be utilized for cardiac ultrasound, for the lung ultrasound, and the abdominal ultrasound. There are additional probes, for example, the convex probe, because of the shape it has as well a 5 to 2 megahertz frequencies and allows deep insonation into the abdomen. The bigger footprint is particularly well suited for ultrasound of the abdomen. A problem is that you need to switch to obtain a cardiac ultrasound, and therefore may lead to several movements that will increase your time of insonation. Your third probe is often a linear probe that you are familiar with from insertion of lines. It has a higher frequencies between 6 and 13 megahertz, and we will not utilize that today. So we have selected the probe, and I'm going to use the sector scanner to perform the abdominal exam, the heart exam, and the lung ultrasound. Always remember to use enough gel to optimize the contact to obtain best imaging. Now, a few words about the probe orientations. Probes have a marker that has to point for the first image, and I recommend to start in the same place, for example, in an epigastric location, in a longitudinal way, and do that for every exam that you are going to perform. In this setting, the notch will point upwards towards the head. In this way, the patient's head would be on the left side of your screen, so this part is cranial and this part is caudal. So let's look at what we're seeing. Going all the way up, right underneath the xiphoid, and keeping the probe relatively flat to the abdomen, you will encounter your liver, and on the cranial part you will see the heart moving. And the first two structures that we're going to look at are the aorta and the IVC. I'm going to freeze this image to explain. So the aorta is located in the left part of the body. We see everything that is black is obviously fluid, and this here is most likely the aorta. Now, how do I know that? We have very regular walls that are relatively echo-dense, and it is not directly connected to the liver. On the moving images, you may have pulsations, though pulsations can be encountered in the insonation of the IVC as well. In order to look for the IVC, there should be a movement towards the slight movement towards the right side of the patient. We are calling this sliding. Let me pause like there. So moving on the body, right and left or up and down, it's called sliding. This movement is called rocking of the probe and allows to look underneath structures or look down towards structures. There's also adjustments as rotations of the probe that allow us to align parallel to the structures. And there's tilting or fanning, which means keeping the probe in one place and tilting right and left. All these movements are necessary for optimal insonation and for image acquisition. So let's continue here. You may often encounter air, as you see it here, that is obscuring your image. And with a little pressure and patience, the air may disappear at some point. But that is variable depending on the patient. So here we go again. We have obtained the aorta in a longitudinal way, which is right here, and through slight tilting towards the right of the patient, I am able to obtain the IVC that is connected to the right atrium and the hepatic vein that starts right here. We call this the happy whale sign. So for the volume assessment, we will try to obtain 1, the diameter of the IVC, and 2, observe if the IVC collapses more than 50% or less than 50% with inspiration, or sometimes utilizing the so-called sniff test. The ideal point to measure is about 2 centimeters from the right atrium, which is right here, and edge to the other side, for the diameter of 1.5 centimeters. This image should be saved, and then we will continue to observe if there is collapse with inspiration, and we can see that it actually collapses nicely. And if I could ask you to sniff, the IVC is completely collapsed there, therefore we can be reassured that the central venous pressure is normal. So the differentiation here is the IVC wide and non-collapsible, very small and collapsed at all times, or is it normal in diameter, which can be variable, with collapse more than 50%. A patient with a dilated IVC more than 2 centimeters and no collapse would be assessed to have an elevated central venous pressure and therefore have elevated volumes. After the longitudinal insonation of the IVC and the aorta. The probe should be turned 90 degrees counterclockwise to obtain a transverse cut through these structures, which are the liver, the aorta, and the IVC. With a tilt looking far underneath the xiphoid, this requires adjustment of the depth. You will obtain the so-called subxiphoid four-chamber view, which allows you to assess the right ventricle, the right atrium, the left ventricle, the left atrium, and have a first glance at the heart, looking for possible pericardial effusion and an impression on the function of the left ventricle, the EF. A slow retilt back towards the legs will take you to the image where you can see the transverse cut of the IVC, and we will adjust the depth. And the IVC has the 3 hepatic veins that are visible right here, taking the blood towards the IVC. Looks like a sun. So that's a very easy image to obtain to orient yourself for ultrasound of the IVC. For the next part, the ultrasound of the right and left costophrenic angle, the probe is taken into the mid-axillary area on the right and the left in order to obtain a longitudinal view or a coronal view. So this is mid-axillary, coronal cut to the patient, where the probe is basically parallel to the bed and cuts into the patient. What we aim to obtain is this image, which is the liver, the diaphragm that is very bright, and on this side the lung. Though beware, this image here is not the lung, but it is a mirror image of the liver. Lung in itself is very difficult to insonate because of the high content of air. So once we are in this coronal view, you can see when the patient takes a breath in that there's something like a curtain of air coming through. But we are focusing on the area behind the liver, and through a fan movement forward and backward, we are making sure that there is or isn't any pleural effusion in the costophrenic angle. Patients with pleural effusion will have black areas over here, which would indicate that there is an effusion. In this case, there is no fluid, there is no pleural effusion. You can also see that we see 2 structures here. There are 2 parallel lines. And when you think about the anatomy, looking into the patient from the side, the first structure that we should encounter is the IVC. So this is also called the rescue shot for the IVC in case you are not able to view it from the ventral. And even farther away, the second structure here is the aorta. And again, we can see the hepatic veins that end in the IVC at this location. Through a slight movement sliding down the patient's abdomen towards the legs and maybe a little bit dorsal, you will come to this image where you have the kidney. As you remember from anatomy, the kidney is not completely straight in the body, but has a slight anterior elevation of the lower pole. Therefore, for an optimal image of the kidneys, a slight rotation is necessary. So let's take another look. So in this coronal slight oblique position, you obtain an optimal image, longitudinal image of the right kidney with the liver and the kidney right here. Slight adjustments by rotating the probe will allow you to obtain the longest length of the kidney. The measurements are performed in this location and show, in this case, a normal size kidney, the thickness of the parenchyma, which is located here, measured from the edge of the kidneys to the pylon area, 1.4 centimeters is measured here. In this position, it is recommended to save a video clip while tilting or doing a sweep through the kidney in a longitudinal view. Turn the probe 90 degrees counterclockwise to have a transverse view of the kidney, and slide on the body from the top to the bottom. Now there may be ribs in your way obscuring your image, and what you can do is ask the patient to take a deep breath in, which will move the kidneys towards the feet, and then during inspiration, try again to obtain a transverse view of the kidney. Breathe normal. And here we are back again. Take a deep breath in, hold your breath in a longitudinal view, where with a sweep we can also observe for ascites or free fluid between the liver and the kidney. In this case, it is negative. We will now move to the left side of the patient to assess for left-sided pleural effusion, the left kidney, and ascites on the left side. Place your probe in the midline and in a longitudinal way, meaning cranial here, caudal over here, and slide on the body as far as possible. And this side always turns out to be more difficult to insonate. What often helps is to slide farther to the back, dorsal, with a slight insonation to the front, right here. And all of a sudden we will obtain this image where it's ideally you orient yourself to the spleen, which is an organ that is easy to recognize. Looks similar like the liver on the other side. We see here the spleen, the diaphragm, which is bright, and this is the left costophrenic angle with a slight tilt of the probe. We can try to assess for effusion on this side. Sliding footwards caudally, you will find the kidney. The slight oblique insonation will allow to see the kidney in its entire length. Here again, it may be difficult to have a complete view of the kidney because of the ribs and rib shadows. So having the patient take a deep breath in, moving towards the legs and more dorsal in the patient may help obtain the complete image of the left kidney. And breathe normal, which you see right here. We'll measure the distance, about 11 centimeters. Save that image and breathe in, hold your breath, and then a sweep forward and backward. It will allow you to visualize the entire kidney on the longitudinal cut. Breathe normal. We will then turn the probe again 90 degrees counterclockwise and slide over the patient, and you see here the rib shadow covering it at times, not allowing to see the kidney at all times. So you help yourself by having the patient take a deep breath in and sliding further down to obtain a view of the kidney in a transverse cut in all positions. Breathe normal. At the same time, we have visualized the area between the spleen and the kidney for free fluid. There is no ascites. The last abdominal image to be obtained is over the bladder, going relatively low in the abdomen. Hopefully it's full, while tilting on the symphysis pubis, tilting the probe towards the feet. The bladder is not very full in this case. With a short sweep backwards, you can obtain a transverse sweep through the bladder. Turn the probe back with the notch headwards and obtain a longitudinal sweep of the bladder. In this location, you can assess as well for free fluid or ascites that could be present around the bladder. With this, we would be done with obtaining images in the abdomen with a question of dilated IVC, presence of pleural effusions, presence of ascites, seeing the kidneys, and seeing the bladder. And then we will move on to obtain images of the lung and the heart. So now that we have obtained the images in the abdomen, we will move to obtain images of the lung. To do that, we can use the same probe, the sector scanner, but the settings of the machine have to be adjusted. So make sure you change your program to lung ultrasound, because our lung ultrasound is set up in a way to utilize all the artifacts that occur, whereas the ultrasound of the abdomen and the heart will eliminate artifacts as much as possible. So we will go for this to the lung ultrasound setting. Before we start scanning. Now when we look at the lung to assess the volume status, as nephrologists we're mainly interested in the differentiation if there are A lines versus B lines. A lines are equal to aeration and B lines are equal to interstitial fluid. So other than pleural effusion, the presence of B lines is important in the assessment of the volume status. The images to be obtained, we recommend a so-called 4-region ultrasound on both sides, and the lung is, the regions are set up in region 1, region 2, region 3, and region 4. This is easier with a little graph. So while looking for to obtain the first image, we're trying to obtain an intercostal space between two ribs in region 1 while pressing hard against the skin. In order to obtain the optimal image for assessment of B lines, it is recommended to increase the depth to about 19 or 20 centimeters, because that is, for the definition of B lines, you need to have enough depth in the on your ultrasound. And now we're looking for the so-called artifacts, which are called A lines. And A lines are reverberation artifacts of the pleura, which we see right here, and it is reflected here over and over again, and the presence of A-lines means there is no interstitial fluid. The lung is aerated, so no volume overload in this location. So the last step is to look at the heart. We have to switch the setting of the machine to go to cardiac imaging. This will change the picture in a way that the notch is now no longer represented on the left side of the screen, but it will be represented on the right side of the screen. The images to obtain for a basic echocardiogram are the parasternal longitudinal axis, the parasternal short axis, and the apical four-chamber view. So where do we find these? So we position the probe parasternal in a slight rotation with the notch pointing towards the right shoulder and the left hip. Second or third ICR on the left side of the patient. Slight rotations of the probe and tilting will be necessary to obtain the optimal image, which we see here right now. Sufficient depth is important to have a first view, which would allow to also assess for pleural effusions that would be depicted in this area of the image. It is important to have the aorta, the descending aorta depicted here, right next to the left atrium, the left ventricle, and to obtain a relatively horizontal positioning of the septum in this image. So here you see now the parasternal long axis of the heart, the mitral valve opening here, the aortic valve opening there, and the right ventricular outflow tract over here. You can decrease the depth at this point for better visualization and estimation of the EF. One of the questions for cardiac ultrasound at the bedside is the EF, is it decreased, yes or no? Because we try to answer mostly yes and no question. And the answer here would be EF is not decreased. In this position, pericardial effusion can be assessed, particularly if you see fluid anteriorly of the aorta going around the left ventricle or on top of the right ventricle. That would be the question, effusion, yes or no. The answer here would be no effusion. So after visualization of the left ventricle in a long parasternal axis, we turn the probe 90 degrees clockwise to obtain a transverse image through the left ventricle. The image we want to obtain is an image at the mid-ventricle with the papillary muscles, which you see right here, which allows you also to visualize the septum, which is visualized here, and observe the ventricle for ejection fraction and the movement. The EF is normal. An additional sign for volume overload would be septal flattening in systole and diastole, which could point towards right ventricular volume and pressure overload. But for the beginning, it is sufficient to assess ejection fraction of the left ventricle. The last step in the echo is to turn the probe one more time 90 degrees. So we have made a movement from this position, rotated all the way to this position, and look for the apical four-chamber view. These are little fine movements, and this is the most difficult image to obtain because you have to find the optimal space between the ribs and the lung to have the optimal view of the 4 chambers. And as an orientation, the septum has to be placed straight in the middle without squishing the ventricle and make it too short. And we see that the lung is coming in here once in a while when the patient takes a breath in and obscures the view. What may be helpful here is again a little tilting, rotating, and sliding on the patient. Hold your breath. All right, and in this position we are looking at equality of the 4 chambers. And there's no equality, meaning the right ventricle is smaller than the left ventricle. And with this, we have obtained the last image of the cardiac ultrasound for non-cardiologists, finishing with a question of equality by comparing the right ventricle to the left ventricle. While the right ventricle has to be smaller, about 1/3, 2/3 relationship in comparison to the left ventricle. There is no equality here. So to summarize, we have done 3 shots or 3 planes in the cardiac echo, one looking for the parasternal long axis, one looking for the parasternal short axis, one looking for the 4-chamber apical view with the 3 questions: effusions, EF, and equality. And with that, we can finalize the whole volume exam and kidney exam as a point-of-care ultrasound for nephrologists.